This is the Postgraduate Paediatric Orthopaedic video series. I'm Sattar Alshryda. I'm a pediatric orthopedic surgeon. In this video, I'll take you through how to do corrective osteotomy for Blount disease. And this is part of chapter 6 of the Postgraduate Paediatric Orthopaedic book. As we did with all our videos, we base our videos on case studies. This is about a 12-year-old boy who has adolescent Blount disease. He had a gradual knee deformity and now he has pain of the medial joint surface line. This is a clinical photograph from the front and from the back, showing genoverum of around 30 degrees on the left side. And this is his clinical photograph from the side, and you can see there's some element of flexion deformity at the knee. As for the rotation of the bones, we usually measure it clinically by placing the patient on their belly. As you can see on the left foot, there are around 18 degrees of tibial intorsion, to compare to 10 degrees of extorsion on the right side, which is within normal. So the difference between the two sides around 30 degrees. And this is common in children with Blount disease. This can be confirmed by CT scan, but this is often not necessary. These are his long leg alignment views, weight bearing of the lower limb for this child. As you can see, there's genoverum on the left side. And if you look closely at the knee, we can see this is Silver's coiled 5, which is advanced for Blount disease. We can see the double layer of physis. And if we look at the MRI scan, we see most of the medial physis has been closed. So there's no point in doing epiphysiolysis, as this is not going to work. I cannot emphasize enough how important to do a full lower limb analysis in these children, as the deformity often involve both sides or involve both bones, tibia and femur, as you can see in this child. This is the frontal view analysis. We can see the abnormal values are labeled with red. We can see both mechanical axes are not normal on both sides, with the mechanical axis deviation of 89 millimeter on the left side versus 27 on the right side. The lateral proximal femur angle is normal on both sides. The mechanical left distal femur angle is normal on the right side but abnormal on the left side, although the difference between them is 2 degrees only. We'll come to this later in the decision making how we treat this child. The joint line congruence angle is within normal, and there are proximal tibia varus deformity on both sides. The mechanical proximal tibial angle is 76 degrees on the right versus 66 on the left. Much worse on the left, but still abnormal on the right side. The ankle seems to be within normal. When we look at the sagittal views, all the angles within normal, although you can see the mechanical axis slightly passing behind the knee. This might be because the radiographer didn't push the knee in full extension, or maybe indeed there's knee joint contractures. Clinically, you can answer this question when you examine the child. To do a detailed lower limb analysis, this has been explained in our previously published videos, video 23.2, which is a preoperative planning of tibia deformity using TL-HEX software. You always can subscribe for our channel to receive our regular update about these videos. Looking at our deformity analysis, there are 3 deformed bones: the left femur distal valgus deformity and the right proximal tibia varus deformity. These deformity can be corrected by guided growth using plate, because the growth plate in these bones are healthy. However, the varus deformity of the left proximal tibia is not amenable to guided growth because it is already silver skull 6, which indicate that the growth plate is not healthy, and utilizing this to correct the deformity more likely to be futile. There are 2 other deformities are not immediately visible in this chart. The first is the rotational deformity of the tibia, which we alluded to earlier in the clinical examination section. There are 30 degrees of a tibial intorsion on the left side, which we should consider during the correction process. The other deformity is the leg length differences. Now, because of the deformity, the actual deformity, and at maturity, they should be calculated and accounted for. During the procedure we planning to obliterate the growth plate completely in the left proximal tibia. So the child most likely is going to lose around 6 mm each year. He's 12 years old and anticipated to finish his growth at age 15, so anticipate he would lose 1.8 centimeter from his final length of the tibia. We can add this during the correction process so that when he becomes 15, he will catch up, or we can stop the growth of the other side. Choosing between stopping the growth on one side or lengthening of the other side depends on the patient choice. Particularly, it depends on his height in the future as well. If he's likely to be tall, maybe stopping the growth on one side will be the best option, but if his final height will be short, maybe lengthening the short side is better. But we know lengthening is more involved surgery, it's more risk, and it's more time consuming than stopping the growth on one side. Now the patient in the operating room, we did the preparation and draping before the surgery, and we did the left distal femoral hemiepiphysiodesis using 8 plate, and now we are closing the wound. As you can see the marking, we mark the patella, we mark the distal femoral physis for the 8 plate, and also there's a horizontal line which is the proximal tibial physis, and there are 2 lines along the main axis of the proximal tibia and the distal tibia, and there's a small horizontal line where we think our osteotomy will be. As for the hemiplateau elevation, I usually use a horizontal incision, and this is placed at the level of the axilla of the depressed hemiplateau. We need to be careful with important structure here, like the saphenous nerve, the gray saphenous vein, and the hamstring tendons. That's one of the reasons why I changed my practice and now use more vertical incision, which is more friendly for these structures, and I try to get them away from my osteotomy. Also, using vertical incision gives me the advantage of doing the tibial osteotomy through the same incision. Now I reach the axilla of the depressed hemiplateau. I put the tip of my scissor there and I x-ray. And when I'm happy with the position of my scissor or my entry point, I'll go subperiosteal. I'll try to peel the periosteum from the area where I'm going to do my osteotomy. It's essential at this stage to reach and map the whole depressed hemiplateau from the front and the back, and being able to pass your finger on both directions. And this is important because your finger will guide your osteotomy later to prevent a lot of breaching at the back or at the front, and to protect the neurovascular structure in the vicinity. And as you can see here, I'm trying to create a window for my fingers to go behind the bone and in front of the bone for the purpose I just mentioned. Once you are happy with the windows that you created and you can feel in front and behind the bone, you start your osteotomy by various type of osteotomes, whether curved or straight. And here you rely on the x-rays as well as the feeling with your fingers to make sure that you don't endanger any neurovascular in there nearby. Once the osteotomy has completed, we start lifting the hemiplateau up by the osteotome themselves or by lamina separata. This particular part of the procedure requires some patience, and take your time, free the front cortex and the back cortex, and use the viscoelasticity of the bone to its fullest to elevate the hemiplateau. And this is important to prevent a break through the joint surface. I'm happy with this correction. Now I move with the second part of the procedure, which is completing the epiphysiodesis. This can be achieved by drill epiphysiodesis, in which we pass through the growth plate multiple times using a large drill, and whatever left from the growth plate can be removed with the curate. This is a pretty effective way, however it is permanent. After the epiphysiodesis is completed, it is time to put the bone graft to prevent the collapse of the hemiplateau. Usually the bone graft can be snug fit and you cannot remove it, and which is great. However, sometimes it can be loose and needs some sort of stabilization. There are different ways how to do the stabilization. One way is to use cannulated screws, however these can come in the way of your half pin later for the frame. Or we can use the same fine wires for the frame to do the initial stabilization, which is my preferred way. Here I put my fine wire parallel to the joint surface, then I fix my proximal ring, which is big enough to allow for the soft tissue swelling and is open from behind to allow for the knee bend. Then I'll check the x-ray On the AP, I want to make sure that my ring is parallel to the joint surface. And here, because there's a proximal deformity of the tibia, I rely on the distal surface of the femur. As you can see here, my ring is parallel to the distal joint surface of the femur. For the lateral views, try to get the ring parallel to the joint surface when possible. If this is not possible, try to get your ring perpendicular to the tibial shaft. And this happens by aligning the threaded rod in front of the ring to the main shaft of the tibia, as you can see in this picture. However, this is strictly not essential anymore. With the modern software of the circular frame, they are clever enough to understand the position of these rings in relation to the bone and deformities. Once we're happy with the initial fixation, we put another half pin from whatever side. I usually prefer to get it to the epiphysis, above the physis, as you can see in this video. And you can see the trajectory of the half pin. It's going into almost physis, epiphysis. Then we put a second pin. By that, we'll have 3 fixation, as you can see. One at the top, then we have the fine wire, then the other half pin which we added. Now we completed the fixation of the proximal ring, and the rest is standard. We put a second ring perpendicular to the tibia, and we connect these 2 rings with the struts. We remove the front struts to do the osteotomy of the tibia, and we usually choose a place for the osteotomy around a centimeter, 2 centimeter distal to the distal pin of the proximal fragment. And we ensure our osteotomy is complete by seeing translation both on the AP and the lateral view. Finally, we insert syndesmosis screw and we do fibular osteotomy for easier correction, and also we insert a plate to guide the growth on the contralateral side to correct the margina verum. All wounds will be washed and closed using bicryl and monocryl, and a pressure dressing applied. On the ward, we get postoperative orthogonal views of the lower limb. By orthogonal, we mean the proximal ring or the reference ring look like a single line, as we can see with the green arrow. We also need to see the joint surface separated from the orthogonal ring, as you can see by the red arrow here. Another important landmark we need to see on this X-ray is the osteotomy site, as denoted by this red arrow. The same can be said for the lateral view. We need to see the joint surface, the orthogonal ring, and the osteotomy site. You can see we rush through the application of the frame itself. This allows more time to focus on the programming of the frame, which many candidates in our courses ask us to do. In order to do the postoperative programming, we need to log into the system. I prefer to use the Orthofix TL-HEX because it has many advantages over the other frames. So I sign in, and this will take me to the list of my patients. I think I did this patient quite a while back. That's him. Okay, I've done him in July 2019. I already archived his data here, but I created a new active folder for this video purpose. So if I click on it, it will take me to this page here, which is the case management. The first tab on the top is the case data, then deformity parameters, then mounting parameters, schedule, and report. So we have to fill each of these tabs separately. We'll start with the case data. Here the case type is a deformity or is a fracture. Of course, it's a deformity, and this is a real patient, not a trial. The patient ID, I usually use the hospital number, but be careful not to use any identifiable information. Frame ID, I use a frame A because it is a singular frame. If there are multiple frames on this child, you allocate a letter for each frame. Case ID, I usually use the initials. I'm a AAA. Then case description is left leg Blount disease. The planning created on 11th of July 2019, but you can't change the date from here. If you click on it, you can see the date where you want to create the plan. It is left side and it is tibia. Here you can add any note. For example, this video has been created for educational purposes. any note you would like to add. Once you're happy, you can move to the next tab, which is the deformity parameters. Again, if you look at it, this is case management. Here, the patient data that you already entered, the case ID, the case type, the bone type, and the site. We've already filled the case data, and this is the top line populated from the case data. Now we are in the deformity parameters. The first square here, it will ask you whether you're going to use proximal referencing or distal referencing. Here in this patient, we use proximal reference because the proximal ring is closer to the site of deformity. That's why I prefer to use proximal referencing. Again, you have two options, either to use HEX X-ray, which I prefer, or manually enter the data. By manually entering the data, you measure them on the X-ray and you put, for example, if you look on the AB view, how much deformity, you put it there, whether it is valgus or varus, how much translation on the AB view, whether medial or lateral. The same you do it on the lateral. Whether there's angular deformity, is it procurvatum or curvatum, and the magnitude of it here in degrees, and whether there's any translation. Again, for axial views. This has been fully explained in our videos in the deformity correction playlist. So please go to refresh your knowledge about it. As I said, I prefer to use HEX X-ray. So if you click on it, it will take you to another window, which is called image window. Here you can see AB and lateral. And you can upload your videos through a different way. Either select the file and upload it, or copy or paste or drag and drop. And I'm going to upload the AB here. If you click on the upload, you look for your AB images, and I think this is my AB image, and I'll drop it there or upload it there. Take a few seconds, then it will come to here. The first question you will be asked once you drop the image here, make sure that the orientation of your image is correct. By this I mean the top is top, which means this is the top of the bone, this is the bottom of the bone, which is correct, this is medial, and this is lateral, which is correct. So if you're happy, you say yes. The second thing, it will ask you to calibrate. And there are two ways to calibrate, either to use a line or a circle. Here I have the circle, the calibration ball, so I can use the circle, and you can see this change for a circle. If you don't have the calibration ball, I usually use the width of the ring because this is around 10 millimeter or 1 centimeter. So our calibration ball, it is 25 millimeter. So I'm trying to fit it as good as possible. I put 25 millimeter, then I accept. Then automatically move to the lateral. I'll do the same. I'll go for the lateral views. Again, I upload it. Again, it takes a few seconds. Then here we are. And again, it will ask you, is the orientation correct? Top is correct. Anterior is correct. Posterior is correct. So I'm happy with that. It will ask me again for calibration. And I will use circles. And I drop my circle to here. And here 25 degrees, 25 millimeters, sorry. And you have the two images now, the multiple images. I'm going to just make them smaller so that I can see them better. There's a lot of features of this software. You can explore them. In this step, it will ask me to place the osteotomy. So if you click on place, and this red line, you should place it on the osteotomy. That's here. And that's here. Try to fit it as good as possible to your osteotomy. I'm happy with this, then I will lock it. See, as you lock it, it will move again. It will give you a sign to move that way. I'm going to click on this one. It moved me from the image tool to the deformity analysis. Let's spend a few seconds in this page here. You have the deformity analysis here. You have your AB image. You can use AB, you can use lateral, or you can use multiple. You have to save and you have to print, and you have more information here should you wish to read more. Also, if you look here, guide, that's very useful as well. If you click on guide, it will take you to video what to do in this page. Here you have to have the alignment tree. You have one for the proximal segment and one for the distal segment. And we're going to come to have more details about these. You can remove them, or you can put them on. You can put the dowels on, which are these little segments to represent the reference and the moving segment. You can remove them. I prefer to remove them because I'd like to see the bone. Here you have an additional measurement tool here to measure distance. You can measure any distance from there to there, and you can remove it, or you can measure angles, any angles you want. Then you have a table for deformity parameters. Any changes here, it will be reflected in this table, and in both the AB, the lateral, and the axial view. Okay, and now let's go in detail how to analyze the deformity. Let's focus on the AB first. Okay, I'm going to slightly magnify it, and as you can see, there are two segments. We have the distal segment, we have the proximal segment. The distal segment is simply a shaft, and it's easier to fit this one in the middle of the shaft and use this as a shaft alignment thing. Okay, so this line in the middle of the shaft, and I'm happy with that. However, for the proximal segment, it is a metaphysis, and it's really difficult to use the line in the middle. Sometimes difficult for us to identify the middle of the bone. So we have to use the joint surface line. As you can see, it's set for 87 degrees 93, which is the normal angle for the joint surface line of the proximal tibia. So I'm going to move this one to sit on the surface lines. This one tip. This is almost correct. Okay, this one. Yeah. Okay. So this is the shaft line, surface line, and they have the angle here with this red diamond here. Slightly distal to the osteotomy, so I might anticipate some translation. Okay, and if you can see here on the AB, it gives you a measurement of 12 degrees of varus versus 1 millimeter of translation. Okay, so we are happy with this. Then we move to the lateral. Again, I'm going to magnify it. Okay, as you can see, the distal fragment we can use as a shaft line. For sure, we cannot see the distal tibial angle or the ankle joint to put these surface lines. So we're going to use a shaft line, which in the middle of the shaft. You can see this line in the middle of the shaft, and this one we're going to use as a joint line. Okay. Okay, if you remember, the posterior tibial angle, the proximal posterior tibial angle is 81 degrees, and usually it's the anterior fifth. So this is almost there. Okay, so this will give us 2 degrees of procurvatum and 0 degrees of anterior translation. I'm happy with this one. Then I'll come to the axial view. Axial view, usually we measured clinically, if you remember from the beginning of the video, and there was internal rotation of 30 degrees. If you remember from the beginning of our videos. Okay, and there's no translation. By translation, the axial view means is it short or long. And you remember what we said, we need to consider that. We knew when we obturated the growth plate of this child left with 3 years, and he's going to be short by 1.8 centimeter. Okay, so having discussed with the child and the mom, and we agreed that we're going to lengthen for 1 centimeter. Then we remove the AT plate from the other side. We obturate the growth plate at that time. So for 1 year, we need to lengthen 1 centimeter. So we tell the software that he's 10 millimeters short, and we lock it there. And if we look at our deformity analysis, this is completed now. We will move to the next part. and this will show us how it looks after the correction. Okay, so there's no angulation in both the AB on the lateral. The external rotation and internal rotation becomes 0. He was lengthened 5 mm on top of the lengthening we gave it to him, which is 1 cm. Okay, because when you lengthen a deformity, naturally it will become longer because it will open here. This like opening wedge, so the amount of lengthening in the middle, it will become 5 mm. So if you're happy, we lock it. Then we move to the next, which is the mounting parameters. Again, let's spend a few seconds to look at this page. We have AB. Look at the AB only, lateral, or multiple. Okay, here it will ask you what proximal ring you use and what distal ring you use. I know what I use 200 mm. It was open from the back. Okay, so open anteriorly, medially, open posteriorly, 200 mm. Okay, then I use distally, I use 180 mm full ring. Yeah, so that's the correct choice. Here you can see a ring on and off. Just see the difference between them. When you put them on, they become thicker. When you put them off, it becomes like line. I prefer to see the rings. And here, match rings independently. We'll come to this feature later. It's an important feature, but let's ignore it for the time being. So this is my ring. I'm going to bring it down. See, as I bring it down, you see the other ring moving. So the rings are connected together. Clicking this off or on, it will make them move separately. Okay, we don't want to do that unless we have to. And this happens sometimes if the two x-rays are not taken accurately, or our osteotomy or reference point is not perfect. So now I'm putting my ring. It looks perfect on the AB view and not that quite perfect on the lateral. So, but I cannot, if I change this one, the other one change. Okay, so I cannot, I have to take one option here. I could make them independent of each other and I could bring this back, but later I have to decide which one I'm going to consider my best ring. Okay, let's carry on with this one. So I fit the ring to the best possible for my reference ring, and I'm happy with that. So here it tells me my ring on the AB view. Okay, on the AB view it is 1 mm lateral to the osteotomy site. There's zero angulation, is perfect picture. There's not up or down. On the lateral, my ring is the center of my ring is 15 mm, which is the center of my 15 mm behind the osteotomy site, and there's no upside or down tilt. Then it will tell me my ring is not rotated relative to the front of the tibia. So it's 0, 0. Suppose this tab, which is between the first and the second, it was here. We have to rotate this to here. Let me show you what I mean. So if I do this one, see this red dot has rotated externally. If the junction, or if the master tab, my master tab, which is between the first and the second strut, was here, I have to rotate it. But luckily I got it spot on. I don't need to do that. So this is 0. And here it asks you the reference ring position is 20 on the AB view. It is 29 mm proximal to the osteotomy site. Okay, and on the lateral is 27 mm. Okay, so here I'm going to use this one, the AB, and I'm going to show you. Magnify this one. Magnify this one. Okay, so now because you match rings independently, you have to choose which one you're going to carry on with. And I usually use, remember these tools I told you about earlier? So I'm going to check how far the center of my ring from my osteotomy site. Okay, so this is how far it is. Let me take it slightly out. It is 31 millimeter. So almost 2 millimeter above what predicted by the software. Let's do on the lateral. Okay, if we do on the lateral, this is the center of the ring. This is the osteotomy. It will tell me it is 31. While here is predicted 27. So I feel the AP view is closer to reality than the lateral view. That's why I'm going to go with the AP view. Once I'm happy with them, I will lock it there. Then I'll move next. Save changes, yes. Now I told the software about my rings, but the only thing left is the struts. The struts, these are populated from the case, but you have to feed them manually if you didn't use the preoperative planning. And strut number 1, it is long, it is 40 and 69. Strut number 2 is long, 35, 68. You know these numbers because you measure them when you finish your operation, or when you looked at your patient, you know these struts with these numbers. Okay, you put them all and you save an update. Once you're happy, you will get the pictures of your frame. Please always match. Look at what you get here on the picture and what your frame actually looks like. And if it looks like the same, you are pretty safe. At the end of the correction, you expect these are the struts, how the length of them, and this is how your frame looks like. If you are happy, you move to the next stage, where you come to the correction. Usually start the correction after 7 days, or you can decide the date. We are planning on the 9th of July, or the surgery date 9th of July. After 7 days, the program will start. Let's say I'm happy with that. It's going to be 16th of July where I start the treatment. I usually correct it twice a day, 10 o'clock in the morning and 10 o'clock in the evening. I don't want this one. And I usually go with daily correction in millimeter, 1 millimeter a day. And you hit calculate, and it will tell you that you need 16 days for your correction if you go by 21 days by 1 millimeter per day. And during this process, you need to exchange one strut number 4. Okay, if you're happy with that, you go to the next. And this is your prescription, which you're going to give to the patient. You can see postoperative day is 0. Then you're going to start your correction 16th of July. Each date you have 2 reading, one 10 o'clock in the morning, one 10 o'clock in the evening. And you have each strut, you have 6 strut, 1, 2, 3, 4, 5, 6. And as you can see, the acute almost remain constant through the whole process, but the gradual one that change. You can count the number of click, but I found this is very confusing. I asked the patient to follow the numbers rather than the clicks. And when you come to strut number 4, you can see it need to be changed on the 21st of July 2019 from medium to long. You can see this is dark color and this is light color. When the color is light, you can change it on that date. But when it comes dark, you have to change it. When I see such a thing, I usually change it because I can change it while the patient on the ward rather than bring him there. So I can use this button here, adjust, and I can change this one to long. And as I change this one to long, I'll put the new number and apply changes. And this will eliminate, will make this as long, and I don't need to change it in the future. So this is some trick to help you to become more efficient with your time. Then you monitor your patient on weekly basis until the correction is full. We'll get a weekly x-ray These are the x-rays from 2 weeks after the surgery, which match what we expected by the correction program. Then these are the x-rays from 2 months, where the correction is completed and the osteotomy starts healing. And this is his x-ray after 1 year, where the osteotomy has healed and most of the deformity has gone. We can see the mechanical access on the right side is perfect, goes through the center of the knee. On the left side is still in zone 1, which is normal, but it could have been better. However, in comparison between the preoperative and postoperative state, there has been significant improvement both in the clinical outcome and the radiological outcome. I hope in this video we summarize the importance of the proper assessment of deformity in lower limbs. In particular, in Blount disease, usually deformity not always confined to the deformed bone, and there are usually deformity in the femur and in the contralateral leg. Proper assessment both on the AP and the lateral is essential for success. And finally, on behalf of the Postgraduate Paediatric Orthopaedic book editorial team, we wish you all the best for your exam and your clinical practice.